I'm a fetal physiologist by training, and I like to now call myself a neurodevelopmental physiologist. So really understanding what happens in the physiology of brain development and what happens when things go wrong. So broadly, what we're trying to do in the pink group in the Ritchie Centre is trying to understand brain development and what happens when things go wrong. And this long-term understanding will really help to understand why children get cerebral palsy and whether or not we might be able to prevent it. So let's start with what is cerebral palsy. Cerebral palsy is really an umbrella term, which means a very broad term encompassing a range of different definitions that broadly describes abnormalities in motor function or in posture. Cerebral palsy occurs as a result of a lesion within the brain during development. This injury is non-progressive, which means it doesn't really get any worse and it doesn't get any better. And predominantly the lesion affects the white matter of the brain, and this is termed periventricular leukomalacia. And if we have a look up here at our coronal section through our brain, essentially what we have is grey matter around the outside, and then this pink depicts the white matter tracts that are relaying information from our neuronal cell bodies out to the body. Now, periventricular malacia represents a lesion around the ventricles in this white matter region. And if we have a look at the tractography up here, you can see that a lesion in this region around the ventricles has really dire consequences for movement and posture, hence cerebral palsy. We know that 95% of the brain injury that underlies cerebral palsy was caused either antenatally, during pregnancy, or around the time of birth. There's no pre-birth test for cerebral palsy, and there's no cure for cerebral palsy. Every 15 hours in Australia, a baby is born with the brain injury that underlies cerebral palsy. So these are really large numbers of children who go on to develop cerebral palsy. And if you have a look at some data from the Cerebral Palsy Alliance of Australia, you will see that the total number of children born with cerebral palsy each year outnumbers all of these other conditions in their entirety, or if we bundle them together. So it's a really significant problem that we currently don't know enough about. What we do know is that there are 4 principal compromised situations, either during pregnancy or around the time of birth, that can result in perinatal brain injury and that can then result in cerebral palsy. These are fetal growth restriction, as we've just heard from Kirsten, intrauterine infection, birth asphyxia, and preterm birth. Now, of course, each of these conditions is likely to manifest at a different time during pregnancy. And Kirsten showed us a really nice diagram of brain development, which I've very much simplified up here, in which our grey matter, or fetal grey matter, is being laid down in the first half of pregnancy, and then our white matter development is being laid down in the second half of pregnancy. I'm going to primarily talk to you about fetal growth restriction today. Now, my group in the Ritchie Centre has a large animal model, sheep model, of each of these 4 compromised situations. And what that allows us to do is to understand the mechanisms by which the brain is becoming injured, so that hopefully we can use interventions or better diagnostics or gain a better understanding of how we might be able to prevent the progression of injury and potentially prevent cerebral palsy. We use sheep for a number of reasons. Number 1, they're around about the same size as a human baby at birth. Number 2, brain development is relatively similar and it's really well characterised. And because sheep are around about the same size as a human baby, it also means that we can use some normal clinical tools that might be of interest, like popping the lamb in the MRI to have a look at the brain development, or using some of the neonatal intensive care setup to care for the lamb after they're born. And I'll show you some images of that as we go through. So as I said, I'm going to primarily talk to you about fetal growth restriction today, which we know predominantly affects white matter development. And so really this is what our situation looks like at the moment. At the moment, children develop cerebral palsy and they might have interventions or therapy to try and help to reduce the symptoms associated with cerebral palsy. But our program of research has implemented a large animal model, which we call our preclinical animal model, in which we can try and understand which babies are going to be affected and might go on to have brain injury. What is the timing of injury, the progression of injury, what are the mechanisms that are being altered within the brain, and then looking at interventions. We also then have a small animal, or particularly rodent animal model, in which we can look at the effects of acute hypoxia, and we can really well characterise the long-term effects of that brain injury, look at efficacy, and also some really specific mechanisms at play. So the aim of these series of studies is to try and prevent cerebral palsy. We've heard from Kirsten a little bit about fetal growth restriction. We know that it's a condition in which the developing baby is smaller than it should be, and this is most often due to placental compromise. And if you have a look at the two babies up here on the screen, they were both born at 37 weeks gestation. They're both boys. Our baby on the right in the blue cap was born at right on the 50th centile and is nice and healthy. However, our baby in the yellow cap was born growth restricted on the 2nd centile, so not terribly healthy. This baby in the yellow cap was diagnosed with complications of the placenta during pregnancy, and what we know is that the placenta probably failed to deliver enough oxygen and nutrients to our little yellow cap baby during pregnancy, which affected development and probably affected brain development also. There are a number of complications and consequences of fetal growth restriction. We know that FGR is the most readily identifiable complication associated with stillbirth. FGR infants, particularly those born severely FGR, are most often born preterm. Chronic fetal hypoxia, which occurs subsequent to poor placental function, causes cardiovascular adaptation in utero, which causes something called brain sparing, where blood flow redistribution occurs to try and spare the essential organs like the brain and the heart. But that also means suboptimal organ development for other organs, and also doesn't spare and ensure normal brain development. After birth, we know that fetal growth restriction has effects on heart development. The heart shape, structure and function are different in FGR newborns. FGR newborns are more likely to spend more days on ventilation, and lung function is compromised, and brain structure and function are also compromised. There are no interventions for FGR except delivery, and this is often preterm. Let's have a look at brain development. What we know is that FGR is linked to a spectrum of functional deficits. In the earliest period after birth, in the days after birth, we know that infants with FGR are said to have different attention. They have different interactions with their parents, and this is the first sign that things might not be quite right with regards to brain development. At 2 years of age, we can start to pick up differences in their motor skills, and in early adulthood, it's been shown that people who were born growth restricted have altered cognition and learning and have lower IQ. A couple of years ago, myself and a couple of colleagues looked at the literature to try and understand how these motor, cognitive and behavioural deficits might manifest. And what we found from the literature is that there is some good evidence from MRI studies and also post-mortem studies of the brain that can tell us some adverse developmental effects that are taking place in the FGR brain. These include a difference in the total brain volume, but most predominantly it seems to be an alteration of the white matter development that is most often seen. So this means a reduction in the amount of myelination and the reduction in the volume of the white matter of the brain. So let me talk you through the preclinical steps that we got to so that we were able to initiate the Protect Me trial. The first thing we did was to set up an animal model of fetal growth restriction. We did this by undertaking surgery on pregnant ewes, and we used a surgical technique called single umbilical artery ligation, which causes placental insufficiency. It causes infarction in about half of the placental bed of the sheep, which means that it's getting not enough oxygen and nutrients, so quite typical of the placental insufficiency that we know in humans. We did this at around about 100 days of gestation, and we then let those sheep go on to term, and the lambs were delivered at term. What we found is that the birth weight of our lambs, and you can see quite easily here, this is one of our control lambs, this is one of our FGR lambs, and you can see that the birth weight of our lambs was reduced in FGR. We saw no difference in brain weight, and we saw an increase in brain to body weight ratio in our FGR cohort of animals. So this is typical of that brain sparing response. We kept the lambs for about 24 hours and looked at some of the behaviour of the lambs, motor and cognitive function, and I'll show you a little bit of that in a moment. But then at 24 hours we collected the brain and performed some histology. The first thing we wanted to do was to look at the white matter of the brain to see whether or not we could pick up white matter, abnormal white matter development, and indeed we could. So what you can see on the top panel are the oligodendrocytes, are the small cell bodies that are seen here, and it's the oligodendrocytes that produce the white matter within the brain. And essentially we had around about the right number of oligodendrocytes, perhaps a few less in the FGR brain, but what we couldn't see well in the FGR brain was this beautiful set of white matter tracks. So we calculated the density of the white matter tracks as seen here, and we also looked for signs of axonal injury in both our control and our FGR brains, and we could see signs of axonal injury in our FGR brain. These are really typical signs of white matter injury within the brain. And these are depicted here, in which we looked at multiple regions of white matter within the brain, and we saw a tendency for a reduction in the oligodendrocytes, and we saw hypomyelination, so less white matter being laid down within the brain. And the white matter that was there was quite disorganised. We tried to look at mechanisms by which the brain might be becoming injured. So what are the things that are taking place that are causing injury to the white matter? And the thing that really stood out to us was high levels of oxidative stress within the brain and production of oxygen-free radicals. This hasn't come up very well on the projector, but really what we've got here is our white matter, our oligodendrocytes and our white matter tracks being stained with CMPAs. And in our control brain, you can mostly just see the oligodendrocytes and the white matter tracks. However, in our FGR brain, it's okay, I'll just describe. In our FGR brain, we've got lots of green, which is showing that it's both the oligodendrocytes and the white matter tracks themselves that are being attacked by oxidative stress within the developing brain. And again, we were able to calculate the amount of oxidative stress and found this to be quite high in the FGR animals. So what we'd showed up until this point is that in our animal model, we could find high levels of oxidative stress and lipid peroxidation markers, particularly this malondialdehyde, which is quite a nasty end product of lipid peroxidation, and also a decreased antioxidant capacity. And this was in keeping, really nicely in keeping with what we knew of the human situation with the placenta that was undergoing oxidative stress when it wasn't working properly. What we also knew is that in babies, elevated levels of peroxidation products in the cerebrospinal fluid are associated with white matter injury. And therefore, what we wanted to do was to try and give an antioxidant during pregnancy to see whether or not we might be able to reduce levels of oxidative stress, both at the level of the placenta, but also in the developing brain. And the antioxidant that we chose was melatonin. Now, melatonin is a hormone that we've all got within us. It's our hormone that regulates our circadian rhythm. So we have high levels of melatonin at night and low levels of melatonin during the day. It's the hormone that you would take if you were taking something for jet lag, for example. What we also know about melatonin is that it's a really nice and really strong reactive oxygen species scavenger. And in high levels, it can also promote endogenous antioxidant production. So this makes it a nice candidate for using in an animal model in the first instance. And what we showed in our earlier studies is that we could find that melatonin could easily cross the placenta and it could easily cross the blood-brain barrier. So it was getting right to where we wanted it to be. So we undertook a further cohort of animals in which we induced our FGR at the same time point during pregnancy, and we let those pregnancies progress. But these mums were treated with melatonin during the pregnancy. And what you can see here is that the mums have this little bit of netting on their back, and so essentially we just placed a pump under the netting and the mum received a continuous infusion of melatonin for the remainder, or basically the third trimester of her pregnancy. And again, we looked at the brains. So what we can see is the same myelination up the top in our control and our FGR animals, and we can look at the levels of oxidative stress within the brain. We then gave melatonin, and we were able to almost entirely restore the myelination within the brain and reduce the amount of lipid peroxidation within the brain. And these are depicted in the bar graphs down the bottom, where melatonin we showed to be a really, really good antioxidant within the brain and restored normal myelination, normal white matter development within that developing brain. We also looked at the neurons to see whether or not the neurons were developing normally and whether they might be restored with melatonin administration. What we found is that we essentially had the same number of neurons within our FGR brain, and these are some images from the cortex. However, the neurons didn't all look normal, so we counted normal and abnormal looking neurons. What we found is that we had lower numbers of neurons within the hippocampus of our FGR brain, and these were restored with melatonin treatment, and we didn't see a difference in the cortex. I'll show you what these animals look like after birth. We don't seem to have any sound, but otherwise that's me in my gumboots trying to encourage this little lamb to walk. And you can see that it has really stiff limbs, which we think quite nicely mimics the postural deficits that might be associated with cerebral palsy. And therefore, over the first 24 hours, we were able to calculate the time it took for the lambs to achieve a number of different milestones, and we showed that melatonin treatment during pregnancy was really good at restoring normal function after birth. Now, so what we showed so far is that optimising brain development in growth-restricted fetuses really requires antenatal treatment, because that's when the damage is being done. However, what we know is that only about 50% of FGR is detected antenatally, even in the best hands. I have a PhD student at the moment called Atul. Atul is a neonatologist, and he's particularly interested in what happens to the FGR infants after they're born. So in this small experiment that I'm just going to explain to you now, we delivered the lambs preterm, and Atul ventilated the lambs for 24 hours, and we looked at what the effects of ventilation, so what are the effects of normal neonatal care on the brain of the FGR animal. And this is our setup. Atul cared for them like they're a normal newborn, human newborn, and essentially we've got lamb here and a lamb here, and all of this gear is exactly as he would use in the neonatal intensive care unit. And what Atul showed really, really nicely is that the brain of the FGR animal, after it's been born and after it's been ventilated, is really, really vulnerable. And these cells here that we've got, that I've just picked out, are the astrocytes. And the astrocytes are quite cool because they provide stability to the blood vessels. And they have these astrocytic end feet that sit on the blood vessels and relay signals within the brain, but also control movement in and out of the blood vessels. This is a normal blood vessel with a nice, happy astrocytic end feet sitting happily alongside, but the astrocytic end feet have all been moved away from those blood vessels in which the animal was FGR and received ventilation. And this is a worry because this allows substances in and out of the brain that perhaps shouldn't be there. And Atul then went on to show that in these dark bars, these are the FGR animals that have received ventilation. They're more likely to have inflammatory products within the brain. And so now what we're looking at is reducing the amount of inflammation within the brain, potentially with some postnatal application of interventions. And Atul's particularly interested in stem cells. Okay, so I think what I've showed you today is that the neuropathology underlying FGR is complex and it's multifactorial. The neuropathology is established antenatally, so during pregnancy, and it has some modifying factors. These modifying factors are whether or not it's early or the placental insufficiency is early or late onset, as Kirsten alluded to before, and whether the baby's born preterm. And we think that what happens in the neonatal intensive care unit is really important for the progression of brain injury also, and Atul is pursuing this line of thought. Many people to thank who have been involved in this work. Thank you.